Okay, good evening, everybody, and welcome to tonight's CPD Me webinar. I apologise, I'm 1 minute late. I was talking to Dr. Akash and completely forgot what time it was, so there we go. But we're here now, so good evening. I can already see participants coming online, so please do use the chat option. Tell us where you're dialing in from tonight, and also what attracts you to this Demystifying Anaemia webinar. I'm always very conscious around spelling anemia, and I had to Google search this twice tonight to make sure I'd spelled it properly. It's one of those words that I never spell correctly on a documentation or a patient report form. So for those who are new, some webinar facts. We can't see or hear you, so if you are still sat there in your Christmas pajamas or your Christmas nightie, then you're very welcome to be comfortable because we can't see you, and equally we can't hear you, so you don't need to scramble around looking for the mute button. If you have any questions for Dr. Akash tonight on anemia, then you can put it into the Q&A box. So there is a Q&A box on your screen. If you're on a mobile device, you've sometimes got to turn it to its side and such, but then you'll be able to see the little Q&A box, and it's like two little chat bubbles. The chat box has just got one chat bubble, and I can already see that 15 people have indeed commented in there already. So that's brilliant. If you are a member of CPD Me, then you will get a CPD certificate that will drop into your portfolio, and all CPD certificates come within 24 hours of the event. So anybody who signs up tonight as a member will also get a CPD certificate for tonight's CPD webinar. And of course, everybody will get access to a copy of the recording, and you'll get an email exactly 24 hours from now, and we'll also have it live on YouTube. And also remember, what happens is your CPD certificate will automatically drop into your CPD Me portfolio. That makes capturing and recording your CPD super simple. If you are on social media, it is always great to have you on board. So please do jump onto Twitter, and you can use @CPDme. And it's always good to see you on there. So please use hashtag CPD Made Simple, and we should be able to catch you on there. If you are a member of CPD Me, then brilliant. Tell us in the chat what you find useful. But if you're not a member of CPD Me, then please do consider joining. You can scan that QR code on screen, or indeed you can go over to cpdme.com and join. And if you scan that QR code, then actually you can join tonight, and it's literally just £1.99 for a 30-day trial, and that'll give you access to over 80 live webinars to register onto with automatic certificates, along with access to over 300 recordings in our CPD hub that have also got automated certificates. So please do jump across there. And if you are a member, again, please give us a thumbs up in the chat. If you're not a member, then take this brilliant opportunity. Along here at CPD Me, we also have some amazing symposiums that we organise. Dr. Akash himself, I think, has featured on 2 of them now, but we have got one organised for the 12th of March, and that's Spotting a Sick Child. That starts at 9 o'clock in the morning till 1 p.m, and that's on Saturday, the 12th of March. So if you want to come along and join Dr. Deshana and some colleagues, that is available now to book at cpdme.com/CPD event, and you can jump over there. And for members of CPD Me, that's just £4.99. For non-members, it's £9.99. So again, another great reason to join us. You could be dialing in tonight on YouTube where we go live. So please do join us or subscribe at youtube.com/CPDme, and you can catch up. We have a week's worth of webinars along there, what's been streamed, and then they get deleted. And then you can access all of the up and coming webinar notifications on our YouTube channel, along with some great tips and tricks to capture and manage your portfolio. So you'll probably already gather and be aware now, we love a little competition here on CPD Me. So tonight we have got 2 books to give away. 2 copies of the Pre-Hospital Care Manual Oxford Handbook, and we normally give these away to people who leave us genuine reviews on either Trustpilot, Google, or the app stores. And so what I'll do is at the end of tonight's webinar, for anybody who's left us a review, I'll put your name in a little raffle bag, and we'll do that live. And then tomorrow on Twitter, we'll announce number 2 winner, and then we'll get these books out to you in the post. But it has to be a genuine review. It doesn't necessarily have to be 5-star. It can be any stars that you think is valid. And I will pop the links in the chat in a second, so you can follow them links and leave us some reviews. If you are a CPD champion at work, always good to download our poster. Or what you can do is just put in there, subscribe me to the poster in the chat now, and we will make sure that we subscribe your email address to that poster, which means every month you'll get a poster you can share with all your colleagues at work that feature all of our monthly webinars. And each month we have a poster that feature each of the webinars. So February, March, April, May, June and July. And then if you have an old poster up, the magic happens because you can still scan that and you can go through to the recording rather than book onto the live event. All that leaves me to do now is hand over to the main event for this evening. So are you there, Dr. Akash?
Hi, yes, I am.
Fabulous. I'm going to hand the screen over to you now.
Thank you so much. Let's get this up. Lovely. So I've decided to add fancy animation to this week's webinar series. Please tell me what you think and whether you think whether it totally rocks it or whether I should change anything. But I'm Dr. Akash Doshi. I'm an endocrine and diabetes specialist. I also specialize in general internal medicine, currently doing my master's in medical education. And I run a website with 200 plus articles, one on anemia and various other things. So do check me out on mythebleep.com. So this is the agenda for today. We're going to cover anemia. We're going to talk about causes, and we're also going to discuss the treatment. So the FBC is the most commonly ordered test. I mean, the reason that I'm giving this talk is the amount of anemia I see is endless. I must see 15 to 20 patients with anemia every day, every time I do the ward round, every time I do clinic, every time I see pretty much any patient. If they are unwell, it's very likely that they're going to be anemic. And so it's really important to you, to me, to all of us that we understand anemia and we know how to, what to do when we see it. So the normal hemoglobin levels, based on your grams per litre, although different countries will use different ranges, are 135 to 175 for men, 120 to 155 for women, but this varies depending on the lab that you're doing, that you're measuring the FBC at. So pay attention to these values. Many diseases present with anemia, and that's why it's so common, but also the reverse is true. Anemia is very common in almost all illnesses. If you have an illness long enough, it will give you anemia. And so it's important to recognize what came first and also whether it signifies that something seriously wrong is going on, just so that you have that ability to pick that up and know what to do. Anemia itself, we know, has a huge impact on quality of life and increases mortality. It increases your risk of developing an infection, developing heart failure. It increases the recovery if you have an operation or if you have any illness. Ultimately, there's a lot of morbidity and mortality associated with anemia. So identifying it, fixing it, treating it is really, really important. So anemia comes from the Greek. It means an, which means not, and emia, which means not blood. In other words, a patient who is anemic because they don't have enough blood. It is one of the most common disorders worldwide, so much so that the WHO has put it as one of their targets. Across the world, 30% of people are anemic. If you look at pregnant women, it goes all the way up to almost between 40 and 50%. I think it's 38% at the moment, based on the last statistic. In the UK, it's less common, 10%, but in pregnant women, it's 20%. These are really harrowing figures. I mean, if 1 in 10 patients or 2 in 10 pregnant women have anemia, and actually the people that all of us see are sick patients, we know that the cohort of patients that we're going to see are going to have much higher levels than this, because it's 1 in 10 of the average person, but we don't see the average person, we see the sick person. And so when it comes to anemia, there are 2 things that we need to consider. One, how urgent is it? And this is always very important. What patient is going to require an urgent admission to manage their anemia? Well, it all depends on how quick the anemia has come on. Because the quicker it's come on, the less time the body's had to adapt to it, and the more dangerous that anemia is in the short term. So if your patient typically has bled out a certain amount of blood, they will start to get a response to that. Tachycardia, hypotension, dizzy, thirsty, drowsy. The fact is, if your patient is hemodynamically unstable or they've passed out, that suggests that the patient is urgently unwell and needs urgent attention. They can have the exact same HB, but if it comes on very slowly, then actually the patient may not really be affected by it so much. They may just get some general subtle symptoms which you might miss, and that's why we do FBCs so regularly. They might feel a bit tired, a bit weak, they may have a bit of a headache, a little bit short of breath, typically on exertion, or exercise intolerance. They might not be able to do the things that they usually do. But these are very non-specific symptoms. I'm pretty sure if I asked all of you guys, you'd probably say you've had one of these in the last week. And so it can be very difficult to pick up anemia. And so really any symptom, if you've got a patient who is complaining of any chronic symptom, it is important to consider doing an FBC. The reason being is that might be the first pointer towards something seriously but being wrong with the patient. But also vice versa, if the FBC is completely normal, that's quite reassuring. If your patient is hemodynamically unstable, they are critically unwell, then the first thing you need to think about is, what do I need to do urgently for this patient? And your approach is basically the A, B, C, D, E. You need to make sure that you secure their airways, their breathing, think about resuscitation with a major hemorrhage call, and they may need fluids, or it may be better to actually give them blood to prevent diluting the HB even further by giving fluids. And that call depends on how fast you can get access to blood. Things to think about, though, is it's normally, if a patient is becoming urgently anemic, it's usually due to bleeding rather than other things. And so it's really important to look at every single place that blood could be coming from: oral, rectally, urinary, so hematuria, or vaginal bleeding, because those are the places that you're most likely to see where that blood is coming from. And it's important to pick that up because we need to stop the bleeding. Anticoagulation is another thing to think about, or any underlying bleeding disorders. And then finally, whether they may have any complications secondary to the anemia. If you lose enough blood, well, the organs in your body can't work. Your liver can get under stress, your kidneys can get under stress, and one of the other complications is your heart can get under stress. And this is what we call a type 2 MI. Which is where it's not that there's a problem with the coronary vessels themselves. It's the fact that the heart is being asked to do so much work to pump around all the little blood that's left, but can't cope because it can't get oxygenated enough by the little blood that's left. Before you do transfuse, please do send off some investigations, because that's going to be really vital, really helpful for us to understand what's going on. Because the moment we give blood, well, we then don't know whether the results that we're seeing are the results of the blood we've just given, or the blood that was there before the patient became unwell. So please do send off things like a blood film, hematinics, so that's your iron studies, your B12, folate, a group and save. So we and really a cross match. So we know what blood group the patient is, so that once we have managed to cross-match the right blood, we can give them the right blood, and also send off clotting, because that will give us an idea of whether there's an underlying bleeding disorder which is causing the current problem. One way of looking at the causes is looking at the life cycle of the red blood cell and seeing basically the fact that at every stage of that life cycle, something could go wrong. So if we look at starting from stage 1, in the bone marrow where the blood is made, erythropoietin is the kind of hormone produced by the kidneys, which stimulates the bone marrow to make these cells. And then the red blood cells circulate around for about 120 days. There could be a problem with the bone marrow to produce the blood. There could be a problem here at stage 2. Either the red cells aren't working properly, or they don't survive for their full 120 days. It's possible that there's lots of phagocytosis because the red blood cells themselves are breaking down. Or you could lose blood from other places. So bleeding from all the routes that I mentioned on the previous slide. If your blood is being hemolyzed, then you'll produce more bile, and so you'll see jaundice here, or you'll see dark urine as the bile is cleared via the kidneys in the urine. And then finally, it may be the lack of the materials to make blood cells in the first place. Bone marrow might be working, but there's not enough iron or B12 or other things that are needed to make the blood. And so understanding how this life cycle goes round and round gives us an idea of all the different places that could be the cause of why the blood is being lost. What we want to do is we want to start by taking history. And that's really important. A lot of people jump straight to the MCV and use that as an idea of what's going on, but actually that's not what you should do in the first place. The first question to ask is this new? Is this new? Because if it is an underlying hemoglobinopathy, that the red blood cells aren't being made properly, something like sickle cell trait or thalassemia, well, actually, in that case, it's going to be a chronic thing, and that patient's going to have had it for years. And so pay attention to that. There may also be family members who are equally affected, and so that can really be helpful. And then finally, ethnicity. The next question is, are they symptomatic? Because that will give you an idea of when all of this has started. If they're suddenly symptomatic only within the last week or two, well, that might point towards the fact that they've started bleeding quite rapidly and urgently, suggesting that the patient is quite unwell and at risk of deteriorating, and actually may need an urgent review. Whereas that kind of subtle symptoms that have been going on for several months might suggest something completely different. Either they've had a little amounts of bleeding, or it might be something else like iron deficiency or other problems, malabsorption. The way I like to take the history is thinking inside out. So everything going in, i.e. their diet, are they getting a nice varied diet which has enough iron in it, which has enough B12 folate, so your meat, your fish, your green leafy stuff, and that's important to think about. Could inside there be something going on that's resulting in a problem? For example, a chronic disease. Do they have jaundice and dark urine to suggest they're hemolyzing? Or is it that they've got cancer? So are there some red flags to suggest that, like weight loss or night sweats or poor appetite? And then finally, is it an out problem? Are they bleeding from somewhere? And so it's really important to ask, has there been a change in color of your stool? Because people won't report that they've had bleeding, and they won't report the fact that their stool has suddenly turned black. Just a change in color in your stool. Have you noticed any fresh blood from anywhere? So have you coughed it up? Have you vomited it up? Have you lost it vaginally? Have you lost it through your urine? Or have you lost it rectally? That's important. And those are the key questions to ask. All the rest of it will depend on the answers to these questions, as well as doing the classic systems review that we do for any history. The next question to ask is, what's the MCV? So the MCV, or mean cell volume, gives us an idea of what the size of our cells are. And we know that the different MCVs will basically be caused by different things. So you can have small cells, normal size cells, or big cells. And this will help us decide what is their likely cause. For low, it's almost certainly going to be iron deficiency. There are other things that can cause it, like an inherited hemoglobinopathy. These tend to cause a very low MCV. They tend to cause MCVs that are often like 60 or something like that. Normal range depends on your lab, but it's about 80 to 90 something. But if it's very low and they are of any ethnicity, particularly Mediterranean, Black, or Indian, then these might be going on. And so sending a hemoglobinopathy screen is very important. Iron deficiency is also very important, because iron deficiency, particularly if you're above 50, could suggest that there's a malignancy, i.e. that there's colon cancer and you're losing blood through that. And so it's important to pick up iron deficiency. But iron deficiency is also very common in the relatively healthier person, for example, women. particularly because of the fact that they may not have the best diet, and they may be losing blood every month. On the other side is high. So high is almost, I probably should have put alcohol at the top. Alcohol tends to be the most common cause. After that, B12, folate are common causes. And so, generally it's always these two. Liver disease tends to be your third most common, and then everything else is so much rarer, like hypothyroidism, for example, that we always see in textbooks. But I'm an endocrinologist. I don't think I've ever seen somebody with macrocytic anemia due to hypothyroidism. Liver disease is also something that should be considered in this cohort. I think it's important just to take a photo of this. The reason being, or just Google this at the time when you were seeing a patient, because there are many acronyms which will allow, for example, TAILS, which will allow you to recognize this, and others for a macrocytic picture. But in all honesty, we are often inundated with acronyms these days. And so I like to just look it up in the situation because it's much quicker, much more accurate, and there'll be a more extensive list just in case I'm missing something. Finally, there's normal. And normal is something that we actually really commonly see. I think these two are the ones that we usually see the most commonly. With normal, it's possible that it's a low and a high, but that because the cell counting has measured all the low ones, measured all the high ones, and then given you an average, the average is back in the middle. And so the thing that's really helpful in that case is the RDW. That's the red cell distribution window. What it tells you is the range. What we expect are all of the cells are roughly the same size, and so we expect the range to be very small. But if the range is very high, then we know that there's loads of small ones and loads of big ones, and that's why it's normal, because we're getting those extremes when averaged are coming nicely in the middle. Acute blood loss can also do this because the body hasn't had the time to compensate by trying to make new cells, the fact that it's lost a lot of iron. So in acute anemia, it will be normocytic. It's also often normocytic in your chronic diseases like heart failure or CKD. So in CKD, you don't have that EPO, that erythropoietin, to make that blood, or inflammatory disorders where you get that chronic inflammatory state, and as a result, you get chronic anemia. If the bone marrow can't make the cells well, if the bone marrow can't make the cells well, some of them will come out all right, but some of them won't come out as well. But the fact is, the ones that do are normal, and hence, once again, it tends to be a normocytic anemia. Hemolysis, well, the cells are normal themselves, but they're just being lost more quickly. And then finally, it might be normocytic because of a dilutional component. This is not that the patient is anemic. This is the patient that has too much fluid, and therefore the hemoglobin looks lower. And so these are the kinds of things that you need to think about, and this will all depend on that history that you take. These are the investigations that I'd recommend sending. And the reason that I don't labor the point of is it microcytic, macrocytic, normocytic is because in reality, you tend to send a lot of the same investigations for most people with anemia, because there are rare circumstances where your B12 or folate deficiency, rather than presenting with a macrocytic picture, will present with a microcytic. And your iron deficiency, sometimes in the early stages, it can present with a macrocytic picture or a normocytic picture. The fact is there's so much overlap, which means that actually it's helpful to just have a little bit of an idea of a set of investigations that will capture most things. It's also possible that people might have mixed deficiencies, B12 folate and iron deficiency, and hence another reason to think about sending off a couple of different tests when you do detect anemia. One of the most powerful investigations, and ones that we miss frequently, is the urine dip. The reason the urine dip is important is because if we pick up hematuria in a patient who we don't expect hematuria and is above 40, well, that meets criteria for a urgent 2-week wait urological referral if the patient is asymptomatic and we can't attribute it to something else, like a kidney stone. That's important because otherwise we might do all of these other tests, then go down the upper lower endoscopy, then the patient will find that wait for the biopsy results, which will then be normal, at which point the patient will then be recognized to still be anemic, and either their cancer will progress, or somebody will think to do a urine dip, and at that point things will be recognized. So by not doing that urine dip, things can be really delayed. It's important. If they're iron deficient, which you'll pick up, so again, you're probably going to do iron studies in anyone who's anemic, regardless of whether they are microcytic or macrocytic. And if they are iron deficient, well, that will prompt you to consider an upper or lower endoscopy to look for cancer in anyone who's above 50. Celiacs is something that we commonly pick up. I mean, given how common it is, 1% of the population, we may well pick up celiac disease. And the only presenting feature may be that they've got an iron deficiency anemia. Next thing to think about is a hemoglobinopathy screen. I think this is really important, those who've got microcytosis, so a low MCV, and who are non-Caucasian, and if they are younger. So you don't tend to pick this up newly in people who are above 75, although I say that having just literally 2 weeks ago picked one up that had been missed because the patient hadn't really presented many times before. But hemoglobinopathy screen is very helpful. This set of investigations looking at urine dip, your celiac, your hemoglobinopathy, hematinics, so B12, folate, and iron studies are very helpful. If there's red flags, i.e. if you're really thinking that the patient's got malignancy, then one of the other things that can be considered is a CT CAP. Which is a CT of the chest, abdomen, and pelvis, also known as the CT TAP, thorax, abdomen, pelvis. I really like this. I'd love to know what you guys think. But anyway, let's go back to the main topic: iron deficiency anemia. I think one of the things that people don't recognize is that actually giving more than one tablet, so more than one tablet of ferrous fumarate or ferrous sulfate, actually has been shown not to improve absorption. This is when I heard this fact, I was just like, wait, what? So if you have more than one tablet of iron per day, you tend to get more side effects, all those gastrointestinal side effects that mean people stop taking their iron. And actually, the absorption isn't any better. If in fact it's worse because of this spike in hepcidin levels, which is made by the liver to help transport iron, and ultimately this leads to less absorption of iron. And so it's important to consider just taking one tablet, and taking that one tablet with the optimal absorption. So it's to optimize that absorption. First, take prescribed iron. A lot of the over-the-counter iron you just need to check, because a lot of the over-the-counter iron has very little iron in it. And so you're taking such little amounts that it's just never going to work. One of the things that you can do is increase your vitamin C. So having acidic things with your iron, like orange juice, really helps absorption of that iron. In contrast, a lot of people have their iron the first thing in the morning when they're having tea, coffee, or dairy because they're having cereal or something. That actually reduces your absorption. The next thing to think about is there are certain medications, particularly these three because they're common, like Adcal D3, levothyroxine, and levodopa, that shouldn't be taken with iron because it can interact with these and make them less efficacious. When you do give iron replacement, you should be considering to give iron replacement for at least 3 months. And at that 3 months, then you can consider rechecking things to see how things are going. Finally, consider IV therapy. I think we don't do IV therapy as much as we should, but at the same time, I appreciate why. It's quite expensive, and there is always that risk of kind of allergy to it, so people can get a bit of reaction to IV iron. But it's really, really useful in those patients who are not able to get enough iron from iron tablets. That might be because of GI side effects, although we really should try and bring them down to one tablet and do all the things to try and improve their absorption before we use that as a single reason for considering IV iron. And we should also switch their formulation. So if they don't tolerate iron ferrous sulfate, we can consider ferrous fumarate, for example. If they've got GI problems, so if they've got a gastrointestinal disease of some sort that would lead to malabsorption, well, then in that situation, giving oral iron isn't really going to work. And the next thing is if they've been taking it for a period and you know they've been taking it optimally and they still haven't had their iron replete, that's another situation to consider. And then finally, actually in your anemic patient who you might think, oh, well, their anemia, their HB is all the way down to 62 or 63. I'm quite worried about this patient. But they're actually relatively very well. They've not got any problems. We're not worried that this anemia is going to cause them any significant consequences. We may consider giving them iron, and they're iron deficient. We may consider just giving them iron and seeing whether that improves things, because it's usually better to make your own blood and correct the underlying problem than it is just to give somebody blood and let the underlying problem go by the side. And so in a certain subset of patients, I won't transfuse them. In fact, I'll try and transfuse as few patients as I can. And I'd rather give them what they need to make their own blood. On the other side is B12 and folate deficiency. We see this fair bit. In this situation, the first thing we need to do is make sure we correct the B12 first, because that can, otherwise, if you just replace the folate and the patient is really deficient in B12, they may actually get neurological complications to that, subacute degeneration of the spinal cord. The dosing is as per the BNF, so we'll advise you 50 micrograms of cyanocobalamin between meals, or it may recommend that you take the iron injections, particularly if you've got pernicious anemia. For folate deficiency, it usually suggests taking 5 milligrams once daily. Do consider pernicious anemia. Pernicious anemia is basically a disorder where you can't absorb B12 because you have loss of intrinsic factor, and so you get intrinsic factor antibodies. This is an autoimmune condition like thyroid diseases or type 1 diabetes or rheumatoid arthritis, and so it's more common in patients who have autoimmune diseases. Finally, once again, you really do want to replace it for at least 3. Actually, for folate and B12, I'd go more for the 4 months and then reassess and see where you're at. It's important to reassess these things because less so for this, because this isn't as dangerous in high concentrations. But iron deficiency, there are some patients who are on this for a very long time and it's not recognized, and they're actually potentially at risk because we're just continuously giving them way too much iron. So that's something that we do need to think about. We do need to stop iron if they become replete, or reduce the frequency that we're giving them if we think that the reason that they're deplete, for example, having periods and vaginal bleeding, is such that we're not going to be able to target that through other means. What we're going to do next is we're going to go through some cases to try and consolidate some of that knowledge that we've gained and work out what we're going to do when we see our next anemic patient, such that we have frameworks so that we feel confident. So here's the first patient, Mr. Foreman. Mr. Foreman's 43. He's presented to A&E. He initially presented to his GP, tired, and feeling a bit unwell, and so his GP carried out some bloods and found that there was a HB of 52, and so urgently sent him into A&E. And that is completely reasonable. Any patient who's got a HB of below 60, I very much think should be sent in for an urgent assessment because that's quite dangerous territory. Between 60 and 70 is a bit difficult. It depends on your patient and how well they're tolerating it, but I would have a low threshold for being safer rather than rather than cautious. Above 70, patients tend to be safe unless they've acutely dropped. So it all depends on the patient in front of you. The first question is, are they hemodynamically stable? We need to think about A, B, C, D, E assessment, and those are really important. So A, airway, particularly in this context where we're thinking the patient may be having some upper GI bleeding because of this dark stool, melena. There is a risk that if they have this large scale vomit, that they may actually aspirate. So that's something that just needs to be thought about, particularly if they come in drowsy. B, well, this patient is essentially shocked. They've got hemorrhagic shock. And so their saturations may be 100%, but that doesn't mean that they are perfusing well. So that needs to be considered, because yes, all of your hemoglobin may be saturated, i.e. at 100%, i.e. that is carrying enough oxygen. But if you don't have enough of it, then you are not going to get enough oxygen, if that makes sense. And so giving that supplemental oxygen can be very helpful in the right context. C, it's really important to consider whether the patient is hemodynamically stable or unstable. In this context, I actually met this patient only a few weeks ago, and they looked absolutely fine, apart from the fact that they were touch intoxicated. And then later on, when I saw them, they were going through a little bit of withdrawal. They were otherwise pretty well. But what made me really worry was that he told me that I was a bit dizzy and that I passed out. And I was like, well, could this be because of the fact that you're drinking so much alcohol? Or could this be because of the anemia? And I erred on the side of caution and just kept him in for monitoring. And particularly because of the HB of 52. And then we got, I put out an urgent hemorrhage call just because he said I had dark stool earlier. And then at that moment, he then vomited up 2 liters of blood in front of us, which was absolutely terrifying. And so it is something to consider. In this context, this is a new anemia. Yes, this patient had been anemic for quite some time, but this drop was fairly new. And they were fairly symptomatic of passing out. So these were things that made me really worry. It's important to ask inside out, because patients often won't report these things. Unless you ask them what your diet is like and really ask them, what exactly do you eat? They will not volunteer that they eat a rubbish diet or that they don't absorb it well. Unless you ask them whether they're having any bleeding from anywhere, and particularly if they've had any change in color of their stool, they will not report that they are having a change in dark stool. And so that isn't at the moment, that is, have you had any dark stool in the last few weeks, the last few months? It's an important question. And then finally, you need to think about red flags, because yes, it's likely that this patient is having an upper GI bleed secondary to alcohol, but it's also possible that there may be an underlying malignancy going on. So it's always important to ask those red flags, because we really don't want to miss a cancer when actually we may have a situation where we can do something about it. In this context, the MCV doesn't really matter. And I know we all get hung up about what the MCV is, but actually we've got the story in front of us. We're going to treat it with what we see. What would we expect the MCV to be? Well, we'd probably expect it to be macrocytic in this situation because of the alcohol excess. We'd expect a high MCV. That may not be as high as we're expecting, because the body may be, due to the dark stool, trying to produce as much blood as it can. And so in that context, it may be a more kind of normalish picture. Whatever the case, we expect there to be lots of reticulocytes. Reticulocytes are your kind of new red blood cells, and that tells you that your bone marrow is working and it's producing these cells. And so that is what we would know then, that bone marrow is working. It is possible, because alcohol is directly toxic to the bone marrow, that might not even be the case. This is why it's difficult to interpret the MCV in this situation, and you shouldn't heavily rely on it. you should do a general screen like you would do for any patient, because that's much more powerful and that's much more helpful. Next is Mrs. Anderson. So Mrs. Anderson is a 73-year-old female who presents to the A&E again following a GP referral for HB of 52. Much the same story. But the difference here is that she is presented with a much more gentle history that's been going on for several months, with tiredness and some more difficulty getting up the stairs, and just generally not coping so well. It's very easy to dismiss these patients because you're like, well, you're a touch on the old side. It's possible that this is because you're now a little bit older. But the fact is, this is new. And as we all know, there are some 70-year-olds who are fitter than me. And that needs to be taken into account. Whatever the case, we're going to start by an ABCD approach to see whether there's any hemodynamic instability. Has there been any passing out? Are there any ECG features to suggest the patient may be at risk of having an MI? We need to think about an ABCD approach in any situation, because the fact is, yes, the patient looks very well, but this is worrying. Is this new? Well, it's very unlikely that this is going to be old, but it's definitely something that we need to think about. How symptomatic are they and how long has this been going on for? Inside out. So again, we're going to ask what her diet's been like, whether she's having any jaundice, or whether she's having any dark urine for hemolysis, whether she's got any red flags such as cancer, or anything else that may be going on in the inside. So chronic inflammatory disorder or chronic illness like CKD that might be contributing to this. And finally, out, is there any blood coming from anywhere? And in this situation, she reports that there is no blood that she has seen anywhere. But there is a little bit of weight loss. There are a few worrying features. And there's possibly a change of bowel habits, although she's not quite clear. The fact is, this patient's got pneumonia. She's got a couple of features suggest this might be a malignancy. It's important that we go down that route. The MCV, what we're expecting is, if we're thinking of it's a malignancy, is an iron deficiency picture, i.e. a microcytic picture, with iron studies which support that. The next case is of Mr. Poulos. So just to go back to this, in terms of your iron studies, the most useful test is a ferritin. There's lots of other iron studies that you can send and test for, but ferritin in your well patient tends to be the most useful. It tends to be less useful in your unwell patient, i.e. that with an infective disorder of some sort, because your ferritin may go up acutely. But in that context, you can use your transferrin and your iron saturations to help guide you. Finally, we've got Mr. Poulos. Mr. Poulos is a 53-year-old gentleman, and he's noted to have this microcytic anemia. His MCV is 62, his anemia is not too bad, it's a HB of 103, but this is a bit odd for a patient with a HB of who's 50. An ABCD is unlikely to be of concern here, but it's important to do because the HB in itself doesn't tell you much. It's about how quickly it's dropped and whether the patient is symptomatic. And so it's important to ask, well, important to check whether they're tachycardic or hypotensive. It's important to ask whether they had any dizziness, sudden shortness of breath, sudden bleeding, and all of those fast features that I mentioned earlier. It's important to ask about the inside out. So what is their diet like? And in this context, Mr. Poulos had a very good diet. Is there any evidence that they've got hemolysis, any cancer, red flags, any chronic illness? None of that was there. And then finally, anything out? Well, none of that was there either. He had been noted to have a microcytic anemia, and so had just started, had been told to just take iron supplements. And then was coming back for his review with his GP after about 3 months to see whether there'd been any improvement, and there wasn't. When we looked through his MCVs historically, we found that they were always low. And the fact that and his ethnicity always is something to make you think, well, could this be a hemoglobinopathy? And in this case, he was tested and was found to have thalassemia. This highlights a dangerous situation where a patient may have thalassemia and may actually become iron overloaded. And they may just chronically be on iron supplements because they're always noted to be hypercitic. And actually, they may be very much iron replete. And so may run the risk of having complications of iron overload. And then next is my summary. I hope you appreciate this cool picture of a dog, just because I really loved it. Anemia is very, very common. It's important to ask if the patient is symptomatic and how long those symptoms have been going on for, because that gives you an idea of the urgency. If the patient is acutely unwell or they're hemodynamically unstable, particularly with that dizziness, that hypotension, that tachycardia, that suggests that that patient, regardless of their HB level, needs to attend hospital. But that isn't really news to you, because if the patient is hemodynamically unstable, of course they need to come to hospital. Inside Out is my way of looking at anemia, because it just reminds me to do in a systematic way, to think what is going into the patient, i.e. the diet, what's going on in the inside, like any chronic disorders, CKD, heart failure, jaundice, dark urine, hemolysis, and then finally what might be coming out of the patient. Is there any bleeding from anywhere? Because these are the things that's going to help guide where our investigations are going to go. But we really need to make sure we don't miss cancer. The reason for this is because colon cancer may present with microcystic anemia, with an adenoma, which will be there for several years before it then becomes really, really malignant. And if at that moment it was treated, you may protect that patient from having colon cancer in the long term. And so it's really important to pick this up. With the same thing in mind, a urine dip is vital. A urine dip will pick up those that hematuria, will pick up that urological malignancy, and may stop you having to go down a massive line upper and lower endoscopies when they're not necessary. Hematinics, B12, folate, and iron studies. And when I say iron studies, it's really ferritin. That's the important one. There are rare contexts where you would do other blood tests, so just really rely on the ferritin. A blood film is very helpful because it can give you an idea of what's actually going on, rather than the cell counts, which give you an average. And then consider the cancer screening, the upper and lower endoscopy in the correct patient, and the hemoglobinopathy screening in the correct patient, i.e. that who is non-Caucasian. Finally, do treat your deficiencies for 3 to 4 months. But the important thing is not that it's not the period of time. Most people get 3 months of treatment. It's to make sure that you go back and recheck. Because what you don't want to do is sit on something else that's going on, like a cancer or something else serious, and miss that for many months down the line. And then finally, a shameless plug, as always, for all my articles. So I've got an article on anemia, loads of other key topics, and you can also tweet out to me, catch me on Facebook, Instagram, and see all the webinars that I've done with CPD Me on my YouTube channel. So please do check me out, and please do tweet out to me when you tweet out to CPD Me. Lovely. So now I'm looking forward to lots and lots and lots and lots of questions. So please do ask plenty.
My first question is, we need to develop a cache, what I can have in my pocket for clinical practice, because by gosh, I wish I had an ounce of your knowledge. And I've done a few qualifications and read a few books, but you just blow me away every single time you do one of these webinars. You
are too kind. But to be honest, you do have my number. So you kind of do have a pocket.
You want me to ring you every single time I'm doing clinical practice. That's a good offer. That's a good offer. I'll just say some highs. We've got lots of people on tonight. In fact, Karen from Gloucester. We've got Mark from Wicklow in Ireland. Andy from Sussex. We've got Kirsty from Devon. The weather's nicer, Kirsty, than it is up here in North. Jane, who's an AMP from West Lothian. Paul who's in Cork in Ireland. Evening, Paul. Chris, who's a paramedic from Kent. And Mary Con from Bridgend. So lots of fabulous people join us tonight. We've also got lots of fab people who's just left us some reviews. So thank you to Mark, Luke, Kim, Sam, Anna, Michelle, Lee, Carlos, and Harry, who's left us some reviews on Trustpilot. Somebody's pinched my magic folder that I put all the things in, so I've had to revert to this headphone case to do the raffle, which we'll do at the end. Let me just share my screen, and we'll tell you what's happening next, and then we'll do some Q&A. So just let me find out which desktop I need to share. Desktop 2. So you should be able to see that now, Akash. Can you see that?
Yes, I can.
Fabulous. So we've decided, the team in the office have decided that they were going to send a CPD certificate to everybody tonight. So everybody who's attended tonight's webinar, you will get a CPD certificate, and we'll get that out to you first thing in the morning. So now's a great opportunity to download the mobile app, and the app will notify you, like it says on screen, once that certificate has arrived, and that drops directly into your portfolio. Then all you need to do is go into the app and dictate what you have learned from tonight's webinar, and that will form a perfectly formatted piece of CPD, and it really does make recording CPD Me simple. We guarantee that, in fact, or we just give you your money back if you become a premium member. Webinars coming up. We have got this week How to Support Trainees, Mentoring and Good Practice, presented by our very own Dr. Mike Davis, Dr. CPD, as he's known in the office. So please do scan that QR code. That's on January the 20th, or you can join us at cpdme.com/webinar. We've got a webinar on assessment of dizziness, and you've already covered some of the clues tonight. So join Ben on the 25th of January. You can scan that QR code again, or you can jump over to the website. And again, if you download the mobile app, you can register for all of these webinars with one single click. So you don't have to keep putting your first name, your last name, your email address in. It just makes it really, really simple. And then we've got a webinar that I'm pretty confident might have already sold out, on pre-hospital airway management, presented by Kate Crutzen, and that's on February the 2nd. So if you do want to jump on that, jump over there quickly, because I'm pretty sure you'll end up having to jump onto YouTube to watch that, because I think we are absolutely bulging to the brim. But you can get all our webinars across at cpdme.com/webinar, and you can see, I think we've got about 35 listed on there at the moment, and you can see the big whiteboard behind me has got another 60 on there that need to be listed yet onto the system. So let's look at some Q&A, which I think you've got away with pretty lightly tonight, Akash. I'm going to say to you, because you've got one question in the stack from Dean. And Dean is asking, I know we ask about night sweats and its relationship to a possible malignancy when taking a patient history, but what is the cause of the sweats, and why just at night?
That is an incredibly interesting question, Dean. And it's not really well understood. So there are some thoughts, some theories. Loss of circadian rhythm is one. So typically at night, our temperature goes down really nicely to adapt to the fact we're sleeping, and that doesn't happen. And so as a result, we sweat. There's also higher metabolic activity in cancer. And so because of that higher metabolic activity, i.e. usually at night, you're not doing much, and therefore your body isn't doing much, and therefore it doesn't metabolize as much, and therefore you don't sweat. With cancer, that draws on your sugar stores continuously. It's also because then you're breaking things down, your muscles may involuntary spasm. There's lots and lots of theories that are behind this. It's also important to consider the fact that there are so many causes of night sweats, from being postmenopausal to TB, and all of those probably have slightly different mechanisms, which really complicates the matter. So I hope you found that answer interesting, but I also appreciate that it doesn't really answer your question, because it's just not known.
Thanks for that, Dean. You've left us all scratching our heads. Question from Neil. With over-the-counter iron supplements, does this also impact Adcal, levothyroxine, etc.? Or again, are the doses so low to make no difference?
I don't think there is a study that's looked into this. And in all honesty, because obviously I'm an endocrinologist, we see lots of patients with thyroid problems. In reality, most patients, by taking their iron tablets and their levothyroxine, are not massively affected. It's a possible effect, and so it's difficult. I think the response in an individual will be individualized. I don't think you can predict against the whole population. Theoretically, if they're taking less iron, you would think they'd be less affected. But ultimately, the important thing is if you're taking Adcal D3 and you've had a fracture, you really don't want to have another fracture. If you're having levodopa, then you really don't want to have an off period from your Parkinson's. Finally, hypothyroidism is awful. Given we don't know, it's probably best to be on the safe side.
Fab. Thanks, Akash. We've got a question from Sam, who's just put in the chat. What are your thoughts on point of care testing, specifically for pre-hospital or paramedics?
Point of care testing to look at what?
I'm guessing random blood tests. Yeah, I'm not sure how fast you get them back pre-hospital, sat in somebody's house eating tea and toast.
I think that generally point of care tests are excellent and really helpful. In the context of anemia, I don't know how much they would tell you. Would they change who you suddenly admit into hospital or not? Not really. I think you should be guided more on your history and examination. If the patient is able to cope in their own home environment and doesn't report that they are severely limited, then that is your answer. If they are limited or you are worried, then I would always err on the side of caution and admit them. I don't know personally of where point of care testing would change my management plan in a pre-hospital environment. But I mean, do you know?
No, I think there is some studies currently going on there for lactates and for troponins pre-hospital, but I'm not aware of anything that's been published yet that would be useful, Sam. But certainly from an anemia perspective, I'm not sure that it would benefit your clinical decision making. As Akash just alluded to, I think I'd probably go off clinical findings as opposed to. And I don't think that technology is available, to be honest with you, yet. Or maybe it is. Who knows? Somebody's going to come in the chat now and say, I've been using it for years. We have a question from Jane. With chronic disease, i.e. heart and renal, when and how often is it reasonable to repeat iron infusions?
So it depends on what you're using. So if you're using Ferinject or you're using Monofer, there's certain guidance in terms of how much you give when. So for example, Ferinject, it depends on your level of HB, your weight, and so you can give up to 1 gram in a dose, and then you may need to repeat that a week apart. And then once you've achieved that, then you'd expect the patient to be iron replete for a good long period of time. But it depends on why the reason for their iron deficiency in the first place. Is it because they're losing blood? Is it something that we haven't fixed? Well, if that's the case, then we might need to target that. Also, often in the patient with heart failure, we're quite worried about them being anemic. So we may give them a blood transfusion, we may give them an urgent iron replacement, but we may also then start supplemental oral iron. And so that might lengthen the time before we need to give any more.
Fabulous. And we've just got time to slip one more question in from Stephen. Is there any further complications if someone has a thyroid problem as well as B12 deficiency, which needs watching?
If they've got thyroid problems and a B12?
Yeah, he's asking is there any further complications if someone has a thyroid problem as well as B12 deficiency?
I think the important thing to consider is that most thyroid diseases are autoimmune in nature, the most common ones anyway. So if a patient's got B12 deficiency, that would raise my suspicion that there is a likelihood that this patient has pernicious anemia. And if that is the case, if we give oral B12, well, it's not going to be absorbed because they still lack intrinsic factor. And so in that situation, you need to think about your IM replacement. You need to think about tests for pernicious anemia.
Fabulous. Dr. Akash, look at that. Perfect on time, 9 o'clock. Right, let's reveal the winners. This is the most exciting bit now where the raffle goes live. So let's do the raffle. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We've got 10 candidates who I've put in the box tonight. You can still leave us a review and I will go live on Twitter tomorrow and reveal the next winner of the book. So I've got 2 copies here to give away tonight. And we'll do a 3rd copy tomorrow on Twitter. If you want to buy a copy of these books, They are available on the trauma care website, traumacare.org.uk. I think they're about 30 quidish, and I think you'll get a signed copy as well if you go across their website. So I will close my eyes, roll my sleeve up like Paul Daniels, and I will pull out a random winner. So the first one is, I'm sure there's a better method to this. Maybe someone can suggest it to us. We have got Mark Railton, who's just left us a Google review. Mark, drop me an email, please, andrew@cpdme with your address. We'll get that in the post to you tomorrow, and we'll do another winner for tonight. And then anybody leaves us a review between tonight and tomorrow, we will go live on Twitter tomorrow and reveal it. So our next winner is that back to front? Oh, it's upside down. Kim Withers, who's just left us a review on Trustpilot. So Kim, again, thank you so much indeed. Please drop me an email to andrew@cpdmeet.com and I'll get a copy of this book. I have just put the links in the chat, so please do leave us a review and I'll make sure I put everybody's name in my little box and we'll do another reveal tomorrow on Twitter. Dr. Akash, thank you so much indeed again for a fabulous webinar.
Thank you. It's been an absolute pleasure. And thank you so much, everyone, for paying attention.
You're just a machine. You just go on and on and on. Thank you so much indeed for everybody out there tonight. I'll put the links in the chat again. Download our app, cpdme.com, and you will get the certificates. I will make sure that the team send that out in the morning. So thank you to everybody for joining us. If you are at home, kick off your slippers, enjoy the rest of your evening, and maybe pour yourself a cup of tea or a glass of wine or whatever you fancy, peppermint tea maybe. If you're not at home and you're working, stay safe. Thank you for all your hard work, and thank you for supporting CPD Meet. Take care, everybody, and good night.